Hello, I'm Dr. Arif Kamal, Chief Patient Officer of the American Cancer Society, and it's my absolute pleasure to join you to talk about caregivers and navigation, particularly as it relates to using digital interventions in palliative care. So just some disclosures related to what I'm going to talk about. A little bit of the work that I do across the country is really about disseminating what we learn in terms of the innovative ways to do navigation around caregiving. I want to start with my family because fundamentally, family caregiving starts with the word family. And I myself have gone through my own journey with my mother and her journey through breast cancer. But all of us, as we think about the importance of this work, recognize that one, all of us are currently family caregivers of another person who may be facing a serious illness, or two, will become one at some point during our lives. So let's talk a little bit about the importance of family caregiving and digital interventions to help them. I'm going to start by first talking about just the evolutions in serious illness care delivery. We've come a long way in just a short 20 years. I'm going to talk about electronic registries to really build the evidence for what we're doing in the caregiving space, where the gaps are, and how that delivery can actually get better over time. Third, I'm going to talk about the features and benefits of doing education engagement using digital tools to help patients and their caregivers who are oftentimes facing complex decisions, many of times which caregivers are intimately involved in. And lastly, we're going to talk about methods for testing and implementing novel interventions across the entire serious illness spectrum to improve the outcomes of patients, their family caregivers, and everyone who loves and cares for that person. I want to start by first acknowledging several different people who've helped me along the way too. Recognize that just like the ecosystem for family caregiving is not just one person, it's a community. There's a community of people and organizations who are also similarly interested in how to improve the research, the implementation, the care delivery, and so on. And these are just some here on the slide demonstrating who's helped me along the way as well. So how is palliative care evolving? Let me first start with the field itself. So palliative care is sort of this term that we've been using for about 20, 30 years, but not everyone can actually define what it is all that well. In fact, there was a public opinion poll done about 20 years ago or so that asked about 800 people over the phone, just randomly called, what does palliative care mean to you? And you know what? Less than 9 out of 10 people could actually had misunderstandings about it, and less than 1 out of 10 could actually describe what it is correctly. What people thought was that palliative care was synonymous with end-of-life care, recognizing that maybe there's not a difference between palliative and hospice care. And what we learned is that it's important as a medical field to talk about it in a way that's really understandable to the average person. Because at the end of the day, I promise you, palliative care and hospice care are things that all of us would want when facing a serious illness, but very few of us sort of can identify as exactly that type of care. So let me start with the definition. It is specialized medical care. What does that mean? It means that there's people who do special training in both palliative and hospice care to provide their avenue of care. So if you're a physician or a nurse, you may be focused on the symptoms, meaning how someone physically feels as they're going through a serious illness. If you're a social worker or a chaplain, you're very interested and have the special skills to think about what are the complexities of living through a serious illness to coping with it from a spiritual and religious perspective. And so when we talk about that, we're really talking about a team of people. Now, I've used the term serious illness a couple times here before, and let me talk about what that means. You know, it used to be that serious illness was, we thought about the stage or severity of illness that a person had. For example, I'm a medical oncologist, I'm a practicing cancer physician and an outpatient palliative care physician, so I see patients in clinic. And it used to be that we said something was serious if you couldn't survive it, or it was, stage 4 or grade 3 or something along those lines. And what we've really come to now is an understanding that says a serious illness is not defined by a physician like me or a nurse on my healthcare team. It's really defined by the person who's going through that journey. What I mean is, if early stage breast cancer has a 95% cure rate, that's wonderful. But it also means that 1 in 20 women, for example, will not be cured of their breast cancer, and it will be something that will live with them for the rest of their life. What that means is that for that person, that may be very serious. And in fact, for all 100 women with early stage breast cancer, it's a very serious thing, right? Because of the concern that it may come back. So what we say is that patients and their family caregivers get to define what is serious to them. And in that definition, then get to ask for this type of specialty care, which here we call palliative care. The idea is to focus on providing relief from symptoms and stress of a serious illness. We recognize that people are generally going through their normal lives, and then all of a sudden, right, a diagnosis comes that just completely turns their world over. And when that happens, we think about an extra layer of support, kind of a tagline we use in the field, that says that going through this journey alone can be very tough as a patient, but importantly as a family caregiver, right? Because oftentimes the health system is very focused on the person with the illness, right? The diagnostics, the treatment, the laboratory, etc. But there's oftentimes the person in the room at the same time who is experiencing it, the serious illness, with just as much sort of stress is the caregiver. And we want to make sure that both are being cared for equally. So what palliative care thinks about as the unit of care is both the patient and the caregiver. We provide equal attention to the person experiencing the illness physically and the group around them that's experiencing it emotionally, logistically, financially, and so on. The idea is to improve quality of life, recognizing that for some people, we can't fix everything, right? The goal of healthcare in many situations is we can't take away the thing that may be making a person's life shorter than what they would like it to be. But what we can do is be present for the threats to quality of life, right? That may be affecting both the patient and their family caregiver. What we recognize, for example, is that family caregivers who are going through this journey with their loved one also experience significant threats to their own quality of life. For example, there are higher rates of medical illness, oftentimes because caregivers are neglecting their own health care because they're having to spend time on their caregiver, all right, and the person they love. We also recognize that there are higher rates of depression and complicated grief that also happens. There's also higher financial risks and toxicity because, as you can imagine, the caregiver is the one who's oftentimes bearing the brunt of the financial complexities of paying for healthcare bills and the rest of the bills that come because life doesn't stop, right? Just because there's an advanced illness diagnosis. So together, what we see in this type of care is that both people are important, the patient and their caregiver, and both are equally important to take care of their needs because the outcomes of one are dependent on the support of the other. So let me talk about the history of palliative care. For many people, they haven't heard of it as a medical care, and that's because it's relatively new. So if you look at the history book itself is actually kind of just a few chapters. It starts with the advent of hospice care, which many people recognize as a really well-proven, evidence-based, nationally available way to improve the quality of life of people and their caregivers near the end of life. And what we recognize is if it works so well, as we have known since really the mid-70s and then the large proliferation of hospice around the country from the early 1980s, is that type of care is really helpful to people. And now we have to think, well, if it works so well, meaning that being that it's multidisciplinary, physicians, nurses, social workers, and chaplains, physical therapists, and others working together. And if it improves quality of life and makes people feel better, should we think about it in all parts of healthcare delivery, not just at the end of life? And yes, the answer to that has been the growth of palliative care to be, for that purpose. So, the field really sort of solidified in the late 2000s as multiple large government reports and others started to come out. And what patients and their caregivers started to say is, hey, this is really great. Can my sister have this? She's not dying of anything, but she has this complex disease. Or could her husband benefit from this as well? And what we recognize is, as a healthcare system, is that we have to provide, high-touch care that is kinder and gentler to everyone that's involved in that space. I mentioned that I'm an oncologist. So as a cancer doctor, we recognize very clearly that if you take a bunch of patients, regardless of the cancer stage that they have, one of the best predictors of their outcomes, meaning survival over time, is whether or not they have a close family caregiver. Now, we can all imagine why that may be important in cancer care. It has everything to do with the fact that, we give, for example, chemotherapy every 2 or 3 weeks. That means someone needs to bring them to the appointment, stay with them throughout the day, drive them back home, patients when they are oftentimes sleepy or not feeling well after an infusion, right? Caregivers are key to us being able to deliver cancer care. Now imagine that for heart disease and lung disease and liver disease, that there is both the keeping everything, the trains running at home, which is really on the shoulders of caregivers, while also providing health care, oftentimes, unpaid as sort of a part-time nurse to the person that they're taking care of. And remember that oftentimes health systems don't acknowledge that this has happened, right? As physicians and the nurses, we see them, but oftentimes family caregivers are quiet or are there bearing the brunt of a lot of things. And one of the things we try to do in palliative and hospice care is to turn deliberately to the caregiver, look at them, ask them, well, how are you doing? And that requires deliberate attention and time and space, because oftentimes what we're asking about can be, a really complex thing to talk about, particularly in their loved one. What we know is that sometimes caregivers feel like they're at the end of their rope, and what they need is additional help, either professional or through peer-to-peer support. And it's our job, frankly, as clinicians, to be asking that question. And at the same time, we want caregivers to feel like they can raise their hand and bring it up as well. So as you can see here, the reason oftentimes why healthcare professionals are not great at doing this is because, frankly, there's not been a lot of deliberate attention shined on this issue. It was that caregivers are sort of the silent people who are helping us, but we don't need to answer or ask a lot from them. But remember, now what we're trying to do is actually say, let's do a standardized assessment of the caregiver, assess what their needs are to understand financial, housing, logistical, transportation, and other things that are coming up. And what can we do as a health system to be able to help them? I will tell you that the major payer, insurance provider in the country, which is Medicare, is now emphasizing that there are standardized assessments of caregiver needs, meaning what's on your mind, what's bothering you, what could be helpful with, and are requiring health systems to be increasingly involved in solving those problems with the caregivers, so that caregivers are not sort of the silent partner in the corner, but really we're paying attention, as we have been in palliative care, but as an entire health system, to the needs for both the patient and the caregiver at the same time. What we know now, too, is that palliative care, as it gets increasingly integrated across the healthcare system, is that there's really a continuum or a funnel here. The idea being that everyone, regardless of their disease or severity or stage or others, and their caregivers should have access to specialty palliative care. Sometimes that's provided by the usual clinical care team, the oncologist, the cancer doctor, the pulmonologist, the lung doctor, etc. But that as the needs get more complex, right? For example, a caregiver says to me in clinic the other day, I'm just not sure how much longer I can do this, Dr. Kamal. And honestly, that's not an uncommon thing I hear. Yeah, I hear it because I asked the question, right? And other versions of questions like that are like, hey, what would you do, caregiver, if things got really bad over the weekend? Tell me what you would do. And oftentimes caregivers say to me is, I don't know. I guess I would call 911. And we know that in front of them is an 8-hour time in a waiting room, et cetera, in an emergency department. That's not the ideal place. What we want to do is engage family caregivers, right, as our eyes and ears on the ground, right? People who can sense, sometimes through intuition, sometimes through just a measured way where they just kind of know, that says, I think something is going to happen in the next couple of days. And I want the healthcare system to know that and be able to intervene in the right way. And so here, what you see on the screen is really our sort of approach to saying, well, as needs get more complex, there needs to be higher touch from people who really understand how to assess these needs. And in my case, I'm talking about palliative care. Hospice does this too. And then be able to put an intervention in a just-in-time type of way. The other way we're thinking about this too, across all of healthcare delivery, is calling out this need as an actual expertise and deliberate need that must live within all the places that healthcare is delivered. And so what we talk about here is, what are those needs and what could they look like? They could be sort of basic needs, like just assessing, hey, family caregiver, how are you doing with all this? Seems like a lot going on. How are you coping, right? To more of a champion approach, which might be a caregiver says, well, I'm having a lot of trouble. How can someone help me sort of get connected to the right resources, like a food bank locally, right? Or to resources from the American Cancer Society or others. And how can I get connected to other caregivers like me? We call that sort of the champion level connections. And then there's specialists, truly for those who are having difficulty that really require, dedicated clinical care. And what we recognize, for example, is that there are health systems and cancer centers across the country who are now setting up and have had for a while caregiver-specific clinics. Imagine the concept of a patient and a caregiver walking into a clinic or a hospital. And we say, okay, well, the patient and the caregiver are going to go to an appointment together. And then when that appointment's done, they're going to split up. And the patient's going to go to their appointment to talk about some specific things. And the caregiver is going to go to their own and talk about what's on their mind. Right now, both are getting prepared for things that may happen over time, but both also have the freedom to discuss their issues individually and together at the same time. So let me take a step back. Okay, we're going to rewind here for a couple hundred years. I'm going to take you to the year 1876. Now, a lot of things happened in 1876, but the most notable one to me is that was the year that the most commonly used navigation and care communication intervention in the history of the world for healthcare was invented in 1876. And you know what that was? That was a telephone. So in 1876, the telephone was invented. And what we recognized is a lot's going to change over that period of time. Now, what we recognize is in 1876, the reason why people died, okay, was because of things that lasted for a short period of time, generally viral and bacterial illnesses. The concept of caregiving, be a family caregiver, means you were there providing support for a week at the most, right? Because we were dealing with cholera in the United States. We're dealing with tuberculosis. We're dealing with diarrheal illnesses and other things, pneumonia, managed the Spanish flu, right? Things like that, where really the time course of an illness was measured in hours to days to maybe a week or two. Now, fast forward to today, barring COVID, and by the way, even with COVID, the average time on a ventilator is still 30 days, right? COVID is not a quick thing. We're talking about serious illnesses that are life-threatening, like heart disease, cancer, liver disease, dementia, where either prognostication, meaning the ability to predict when someone will succumb from that illness, is close to impossible or very difficult to do, for example, in Alzheimer's dementia. And what we're doing is we're measuring time now in months to years to potentially even decades. What that means is that the responsibility of the family caregiver in 1900, from a time perspective, is very different than today, where that responsibility now is measured over months to years, potentially even decades. And what that starts to introduce is this whole concept that caregivers, it's not a flash in the pan, right? You're not coming, doing something, and then you get to be done. This is really a marathon that you're running, not a sprint. And so there really needs to be dedicated resources to these folks who are providing this care over a long period of time. What we've been trying to do in the field is being really connected to family caregivers and understanding rapidly how we provide better support. When people think about healthcare delivery and how new evidence is developed, we oftentimes think about the randomized controlled trial or clinical trial. The challenge with a clinical trial is that it takes years to complete and oftentimes a decade before we know the results. And we know that with all the serious illnesses out there, heart disease, lung disease, liver disease, that the interventions for how to support family caregivers can't take a decade to develop, that we actually have to be keeping our eyes and ears to the ground and thinking to ourselves, what's the best way to do this and how do we implement that quickly? So one way to look at that, and this is to teach all of us at the same time, is that medicine used to think about evidence-based care as its sort of only way to kind of find its way forward. And the idea was that we would do everything because we found a clinical trial or study to demonstrate that that's how we should do it. What's really now the era that we're living in is called quality proof. The idea is that we're not going to be context independent. We're going to be context dependent. And what I mean by that is when you do a study, right, if you're in a clinical trial, what happens is you look for the same people to participate in the study in the same conditions with the same intervention and so on. You're trying to make everything the same. And what happens is even those interventions for family caregivers, when they're then pushed out to real life, sometimes don't work. Why? Because everybody's not the same in real life. And so now the movement is towards doing what's called implementation science or quality improvement. The idea being that we want to know, for example, that the family caregiving needs and issues and interventions in Memphis are going to look different than they are in Manhattan, right? They're going to look different in California than they are going to be in Chicago. That may the background of the caregivers themselves, the situation, the access to resources, et cetera. And so when we think about really equalizing the playing field, and we think about a focus on diversity, equity, and inclusion, we're talking about family caregivers too, because fundamentally, those gaps in equity are oftentimes majorly felt by the caregivers. Because, well, what it is access to care, right? I've taken care of caregivers where they say, well, if I had to call an institution to figure out how do I get to the right resource, I've had to call 6 different people to find out. Caregivers are doing this hard work, and we as health systems have to say to ourselves, well, how do we do our own quality improvement? How do I call the number that we have at our institution? And how do I make sure that we're not asking people to do 6 calls? Because ultimately what happens, right, is the harder we make people it harder to do the right thing, the less of that will happen, right? And that's fundamentally the ethos of quality improvement. So the other thing that's happening in healthcare now is digital health. I would challenge that most of you probably in your pocket somewhere have a phone, which means that you are connected to the world, to your caregivers, to your patients, to your clinicians, et cetera. And what we know is that digital health is evolving in multiple different ways. So for example, this slide shows the amount of investment that's happening. Imagine during COVID, a huge push on telehealth, right? For many of you, your appointments might have been over a screen, right? Where you're talking to another clinician. And I can tell you now that based on Medicare and other commercial payers and so on, huge movement towards telehealth. But we can imagine a future where there will always be the option to do many visits via a screen. And there's a lot of movement now in telehealth too. Imagine that you are sitting at home, and in fact, there's a future where chemotherapy might be done in people's homes, where other interventions that we think about going to a hospital or a clinic to do are actually going to happen in the comfort of your own home. Now, what that requires is monitoring, right? What are we going to monitor? People's vital signs. We're going to monitor how they're feeling, how they're doing, and at the same time be able to monitor, for example, the caregiver. We know, for example, that caregivers are really good at telling us a couple days before a person with Alzheimer's dementia is going to start to have a decline in how they're doing, that intuition is really important. In fact, caregivers are the ones to first notice that someone's taking less steps in the day, eating less communicative, less ability to laugh and other things that we know happen outside of a clinic room, right? That's not happening in front of a clinician. And so caregivers can be called upon to sort of say, well, tell us about that experience. Tell us and let us know, so that prevents that person from going to the emergency department, as an example. And what's also happening is there's more publications in digital health. Really, the future of family caregiving in serious illness is going to be a lot about home-based personalized care that's going to involve a lot of digital interventions. There's already hospices, for example, right, that do certain visits over telehealth, but also remote monitors. Imagine if you were wearing a watch and it could monitor sort of your own stress levels as a caregiver and the patient that you're taking care of, and that the two pieces of information are actually combined together to come up with a score to sort of say, well, here's how the patient's doing. Maybe they're doing okay, but the caregiver is less interactive, right? Maybe they are, leaving the house less, which we can monitor actually through geofencing. If they're leaving the house less, maybe because they're having to stay closer to the home to take care of their loved one. Well, that may be actually an indirect or early sign that something's going on that we want to get ahead of as clinicians. So let me talk a little bit about digital health. When people think about digital health, they think about technology, right? You think about something in your hand or something that connects to the internet and so on. But really what this is about is increasing quality, because what we're able to do is increase access, right? Is so that people don't have to physically come to the health system to receive medical care, that we have the ability to monitor people in a different way, because 99% of the time they spent is not in front of us as clinicians. So what's happening during that time that we can pick up on and do something about, particularly if we can catch things early. And then third, it gives us an opportunity to scale, meaning that we can do something really cool, for example, in North Carolina, take that same digital approach and then apply it to other states in the country as well, right? And so that's really what this is about. What's interesting is about 77% of folks older than the age of 65 have a smartphone and use it regularly. What we know is that now people primarily, their source of medical information remains the internet. So I think that really this concept that we are going to create a digital divide by using more digital health tools is maybe a little blown out of proportion. But at the same time, what we have to recognize is that not everyone has access to high-speed internet. Not everyone has access to a device that can support those things. And so I think it's an and with approach that we create these innovations to help people. At the same time, making sure that the policies and procedures are in place so that everyone has access to high-speed internet and devices as well. So this is the team that I've been working with. I just want to tell you a little bit about how it takes a village to kind of do some of the work. And I'm going to tell you a little bit about the work that we've been doing to help, really help caregivers feel engaged and activated in terms of their loved one's healthcare. So let me talk a little bit about what we're doing on the clinician side, right? So clinicians, right, are people who go through a lot of education and really deeply care about their patients that they're taking care of. And what we're trying to do is make sure they have the tools to be able to help take care of the family caregivers that are part of the equation. If there's nothing that you remember of everything I talk about, one that you have to is that patients and caregivers are the unit of care. In palliative care and in hospice, that's how we see the world, is the two things are equally important and combined at the hip together. Because what we recognize, for example, is that when caregivers are not involved, compliance with medications goes down, there are less visits to doctors, et cetera, and what that leads to is poor outcomes. And so fundamentally, good healthcare, when you see it happen, means that behind the scenes there is probably a caregiver who's working really, really hard. So what we've been doing in our work is to really make sure that clinicians know better how to engage and intersect with family caregivers so that they're not the silent folks in the room, that we're really taking time to ask about what their needs are and identify those gaps and to close them. So let me first start with some work we've been doing around measuring quality of care. When people think about quality, there's a lot of different definitions a person can use. Quality, but there's a famous Supreme Court case from the 1970s where a Supreme Court justice was reviewing a movie, and the question was, does this movie have pornography in it? It was actually a mainstream movie, but the question, it was French, and so you can imagine a little different than maybe how we might see movies in the US. And so that was the question. And what the judge said, Justice Potter, what he said was that I don't know what it is. He was talking about pornography. I don't know what it is, but I know it when I see it. And I think when we think about high quality healthcare, oftentimes it's difficult to identify or define. But we can have all of us have had experiences in healthcare where we walked away and we said, that felt right? The person, and what does that mean when we said that felt right? Well, I think oftentimes what people think is, I felt listened to. I felt like they really understood what I'm getting at, that I was heard in terms of what I did. I felt like the person really understands the content, right? Like they are an expert in what they do, they're a good listener, and they are a good communicator, and they put a nice plan together for me. Now that sort of kind of mushy, like it feels right, is ultimately we want to get that a little bit more measurable so we can give feedback to clinicians and say to them, you know what, there are some opportunities for you to improve. So we created this thing called the Global Palliative Care Quality Alliance, the idea being that we would measure quality across palliative care organizations across the world so we could give feedback to clinicians and say, hey, how do you think that went? This is how your patients think that went. And that gap we need to close a little bit. The idea being that we would, as I mentioned, clinical trials, because they take so long to do, is that we would deliver care and learn something while we're doing it, right? And that sort of feels like a no-duh, right? Like we should deliver care and learn while doing it. But oftentimes healthcare is not set up to do it that way. The idea being now, what's happening across healthcare is this concept of rapid learning, right? Where we are rapidly learning how to do it better while we're doing it at the same time. And what we created is this concept that we would measure quality and give clinicians feedback at the same time to show them how they could be doing better. Created sites across the country, the idea being that we really want to represent the voices of patients and caregivers from all walks of life and all corners of the country. Oftentimes what we see is that the evidence, right, the data about family caregivers and their patients come from really large universities, which is important. And at the same time, though, I grew up in a town of 15,000 in the middle of nowhere, Missouri, and I know what that healthcare looks like and what the challenges are there. Fundamentally, we have to be able to deliver the same type of high quality serious illness care in Warrensburg, Missouri, as we do in Westchester, New York, right? And so the idea is that we have to measure it in all these places and then get feedback to people, recognizing that clinicians are doing their best, but there may be resources or knowledge or other things that they may lack that we can help them in terms of doing. What we did was collect a lot of different data, and what we can learn from that data is how people traverse through a journey with serious illness. This, for example, is demonstrating several different symptoms or physical changes in people's bodies. This takes about 30,000 patients and starts to kind of map it. And what it shows is the number of people who have like fatigue and constipation and pain that is much higher than we would expect it to be. And it reminds us clinicians that we should be asking these questions, we should be asking the caregiver about these questions, and we should be intervening at the same time. I can tell you that one of the challenges in healthcare delivery is something that I and others call sort of this conspiracy of silence, right? And what happens is that patients oftentimes want to please their clinicians. What that looks like, for example, in my world as an oncologist is patients come in and we say, well, what's bothering you? What's on your mind? Oh, doc, I'm doing fine. Oh, gosh, I'm not sure that could be true because there's a lot going on scans and so on. Oh, I'm fine. And what you learn is that oftentimes the conspiracy of silence is if I, as the patient, don't complain, then the doctor will continue moving forward with the plan that's in place, right? That we're not going to veer off course because something's not going right. I don't want to be a complainer. Now, what I've always trusted and leaned on is the family caregiver, right? Because when I look the patient in the eye and say, tell me how things are going, and I say, things are going just fine, my head immediately pivots off to the caregiver, right? What I want to know is by looking at their facial expression. And you know what? For those of you who are family caregivers, you know how this works, right? Conspiracy of silence might still remain silent, but there's a little bit of a facial expression that I'm looking for where the caregiver goes, right? It can be like literally like this, and we know that that's not maybe necessarily true. That's important to recognize because the same thing, for example, happens in pain. Pain is a common symptom, right? In fact, most people who have advanced illness, regardless of it being cancer or chronic emphysema or lung disease or liver disease or heart disease, have some amount of pain actually. And that pain may be physical, it may be spiritual, it may be emotional, but something that's affecting them. But oftentimes, if clinicians ask, the answer is, oh, no, I'm doing fine. But what we recognize is that if there's pain that's uncontrolled, what it's going to do is lead to people being less physically active. Now, that's a problem. When people are less physically active, they can get sores on their body. Those sores can get infected. That infection can take their life, right? When people are less physically active, they can get blood clots in their legs that may travel to their lungs and cause a huge blood clot as well, right? So what we know is people who don't move as much can get pneumonia as well because their lungs are not moving the bacteria out of the way. But all that stems back to the fact that there's pain preventing this person from being physically active. Now, if I as a clinician know that that's happening and I can intervene on that pain, then what I can get that is that person to be up and around and active and try to keep those side effects away, right? And so this is really important to think about family caregivers as these eyes and ears, right? And to ask these questions because what we know is these types of symptoms are very common. What we also know is that there's lots of good things that happen when we intervene in a right way. For example, this is a snapshot of savings, cost savings to patients, caregivers, and health systems when we can intervene early. The idea being is that we keep people at home, away from the emergency department, away from the hospital, because that's not where they want to be. And what we know is that financial toxicity, right, that out-of-pocket cost, which oftentimes is 20% when you go to a hospital or clinic, goes down significantly when we can intervene on these issues early. And again, that means acknowledging the role of family caregivers. One is being present. Two, for the hard work they're doing. Three is being eyes and ears. And then asking them and trusting what they say as being extensions of the healthcare team. Because fundamentally, if I could live in the same house with that patient, those are the observations that I would be making. Good news is I don't have to do that. I got someone who's doing that for me. Now, what we've been able to do over time is publish a lot about this work and really now create an international alliance with multiple other organizations who are similarly minded to do this type of work. So the new group that's been put together is called the Palliative Care Quality Collaborative, and I encourage you to go to their website to kind of take a look at the work that's being done. The idea here is that we, again, raise all boats through this rising tide so that every patient and caregiver receives the type of care that's an extra layer of support that is then measuring the quality of that interaction and providing feedback so that everyone gets better. And we know that there's opportunities to do that. We know, for example, that one of the most common complaints among patient and caregivers about the quality of care they're receiving is actually about the communication. That really what we know, for example, is that most medical malpractice suits where physicians are named for something in a court suit is really not around clinical expertise or technical proficiency. It's really about communication. And I would challenge and say that that's really where healthcare needs to get better, is we need to become better communicators, not just to the patients, but to their family caregivers, because oftentimes that's the thing I hear. I was the chief quality officer of the cancer center at Duke University for the last decade, and that was one of the most common, sort of areas for improvement that I heard both locally and across the country is, I really love that my doctor is super smart, but what I also want to do is make sure that they're taking the time to listen to me. And I think in that way, family caregivers can be great advocates, as you are, to the work that's being done. So let me tell you a little bit about how we clinicians get better at doing this. So most clinicians are not taught quality improvement. I talked about how that's a way to improve care locally. And so we would create an app called Bite Size QI. Here, the idea is to give clinicians an app, that takes less than an hour to do, that really engages their patients and family caregivers on a QI team, so they're doing QI together. I am a huge proponent for all of you, if you're not working with your local health systems, is to really think about reaching out and saying, I want to be part of the QI process. I think health systems are getting better at inviting family caregivers and patients to be a part of this. But oftentimes there's a skills gap, right? It's sort of like, well, they know how to do QI and I don't. But remember, the voice of the family caregiver is one of lived experience, right? I haven't gone through the health system that I work at, right? I haven't walked through the front door, gone through the check-in process and so on. But patients and family caregivers have, and give lots of great insight into the different parts of that process that can be better. Remember that quality improvement is really about improving processes, not finding bad apples. And that cultural shift is really important, because healthcare used to be about find the bad doctors and get rid of them. Now what it is how do we make the right thing easier to do? And patients and family caregivers' voices should be critical and central to that happening. So what you're going to see now is a video that we've created to help patients, family caregivers, and doctors and administrators who are working together identify the problem through what's called a problem statement at their local health system and to solve it together.
A problem statement is one or two sentences that summarizes the problem you're trying to fix. It is a way to organize and communicate your thoughts about what you think the problem is to others. A problem may seem obvious to you because you live with it every day. However, it may not be obvious to all the members on your team. So why do we need to think about, write down, and share with others something as obvious as a statement of the problem? The answer is because statements of problems are not always as simple as they appear. People in organizations often have different perspectives, which is not only a good thing, but essential to organizational success. However, this may mean that what is seen as a clear problem for you may not be seen as a problem by others who work with you, or by your manager, or the leader of the organization. For this reason, it is essential to discuss, agree on, and write down exactly the problem that needs to be addressed. The problem statement is typically one or two sentences that describes 5 key pieces: the what, where, who, when, and harm. What is the problem? Where? Specifically, where is this problem occurring? Who is this problem affecting? Importantly, not who is causing the problem. When? Over what period of time has the problem affected people? And the harm. Why is this problem important? Or who or what is it hurting? It importantly does not discuss why. Why is this problem occurring? Or who is causing the problem? Or the how. How will the problem be solved? Here is an example of a problem statement that needs some work. Our physicians are always running late, which is causing patients to have long wait times. We should hire more physicians. In this example, the problem statement states exactly why the problem is occurring, suggesting it's the physician's fault. It also suggests how to solve the problem. Let's try again. This time, focusing on the what, where, who, when, and the harm, based on fact and not guessing at why it is occurring or how to solve it. From October to December, patients at the Pine Street Clinic had to wait 30 minutes on average to see their doctor. This led to unhappy patients. This problem statement answers what, waiting 30 minutes, where, Pine Street Clinic, who this is affecting, patients, when, last October through December, and harm, unhappy patients. This problem statement makes no assumptions about why the problem is occurring, who is causing the problem, or how to solve it. It is straightforward, simple, and short, and will form an important part of the charter that you will be building during this module. Keep in mind that getting to a clear understanding of the problem statement may also take doing some homework. For example, maybe you need to measure the amount of time it takes from the time patients check in until the time they are seen by the doctor. Or maybe you need to survey the patients about how wait times affect their experience. Problem statements oftentimes require some work being done before they're made and may actually change over time. But be careful that your problem statement doesn't become too big. A good problem statement is not only specific, but limited to a time period, setting, and harm that is fixable by your team. As you're thinking about your quality improvement project, this step, making a problem statement, is probably the most important step. Take some time to get this right. Make sure everyone agrees on the problem statement and review it during every meeting with your team to make sure it's still the problem you want to solve. On the next page, you will address the what, where, who, when, and harm specific to your problem. Using these answers, a unique problem statement will be generated. You will then have an opportunity to adjust the statement as you see fit. If you get stuck, look for the example problem statements at the bottom of the screen.
Now, we've also created a continuum that is patient-facing digital interventions. And this is both for patients and caregivers, actually. And the idea is that we have apps and tools that people can use anywhere along the serious illness continuum. Oftentimes, these apps are actually used by family caregivers to provide extra support to the loved ones that they're taking care of. The first is called Prep. It's actually an app that's a free download in the iTunes Store or Google Play Store. The idea here is that people oftentimes don't know what questions to ask when they're going to their doctor's visits. I had a project manager work with me, and in that, we were talking, he was about to buy a house. And what he said is, Arif, I'm going to go meet with the mortgage lender. What question should I be asking? And we both sort of went, that's actually the point, right? The point is not what's the answer. The answer to a question is provided by the doctor, right? Or the nurse or the clinical team. But really what people are after is when I'm there, I've got this precious 15, 20 minutes with this person, what are the right questions I should be asking? So for example, if I'm a college student, I should be asking about, do I need to miss classes? Or, how do I get FMLA? How do I become a caregiver and take time off to go take care of, let's say, my ill parent, et cetera? And what we did is we created an app that you register in and just kind of tell us who you are and what's going on. And the idea is it suggests questions to you about what you want to be asking when you go into that encounter. And here's sort of a video example of how that works. As I mentioned, it's a free download. I encourage you to take a look and look around. There are versions for palliative care. There's versions for COPD, chronic obstructive lung disease. There's a version for cancer and uterine fibroids as well. The idea being that as you're facing those conditions and you're like, let me use an app real quick in 5 minutes to know what questions to ask when I'm in that room. That's kind of what the purpose is here. It's, we think, really simple to use. And the type of interventions that I think family caregivers really need to have at their fingertips is to say, okay, when I'm in the room, what should I be thinking about ahead of time? Because clinicians may not bring it up. That has to do with issues that affect caregivers, for example, like financial issues, logistical issues, housing issues, et cetera. How do I best prepare to be a good caregiver? So I mentioned palliative care, and there's so many misconceptions about what it is. What we found even in my own clinical practice is that nearly half of patients wouldn't come to clinic appointments. Because the reality is if you Google it, which you should, a lot of times things come up that seem a little doom and gloom, right? People talking about maybe death or dying or other things. And as I said already, it's for people who want to live with serious illness and their caregivers who want to have their needs assessed and taken care of as well. This is about living, not about dying. In our clinic, for example, palliative care, its approach is about living while dealing with a serious illness. Hoping for the best and oftentimes preparing for the rest, right? Recognizing, for example, I'm here in North Carolina, right? That, sometimes the weather forecast calls for a hurricane coming our way. And what we say is, if the weather forecast says that's what's coming, it makes good sense, right? To maybe save a little water, maybe board up a window, kind of get the house ready and so on if you've got something down by the coast. And what happens? If the hurricane changes trajectory and goes north and never even comes past your beach, it's not like it was a wasted effort. You were prepared for the worst and you were hoping for the best. And that's in fact what happened. And so what we want people to do through a palliative care approach is, right, think through the difficult questions, right? What makes a good day? And what if that got taken away from me would not be a day that I would want to live through? It's a hard question to ask. It's a hard question to answer, but it's one that's important as caregivers and patients think about what's important for them in a typical day. So we created this app called PC for Me. The idea being that we would prepare patients and their caregivers for an upcoming visit with a palliative care professional. The idea being that agency and engagement starts with being in control, right? Patients, oftentimes, what they recognize when going through a cancer diagnosis or a serious illness diagnosis is the thing that bothers them the most, and this is what they tell me in my clinical practice, is I feel like, doc, I don't have any control anymore. Caregivers say that too. They just say, well, I used to be able to plan vacations, and now I can't do that. We used to be able to make plans, and I can't do that. That control of my schedule, my calendar, and what we're going to do, I don't have anymore, and that's really tough. And I agree, it is really tough, because all of us are really used to being in control, and we feel that when it's taken away from us. So here, what we do is we allow patients and their caregivers to set the agenda for the upcoming appointment by teaching them about palliative care. This, for example, is a screenshot from the app. The idea is we're asking them, what do you want to talk about when you come to the visit? Kind of mind-blowing if you think about it. How many times do you get asked as a patient or caregiver, what is it that you want to talk about with the time that we have? And here people get to choose what it is. And then we show them the video of a difference between hospice and palliative care. So I hope you enjoy this. This is really about 3 minutes distilling down why palliative care is different and importantly helpful versus hospice, and how the two teams really work together over time.
Sometimes the differences between hospice and palliative care can be difficult to understand. Knowing the ways that palliative care is different from hospice care will help in knowing in what ways it may be right for persons with serious illness. First, let's discuss how hospice and palliative care are similar. Both focus on quality of life during serious illness, use a team of experts to address quality of life issues from all angles, and are generally covered by Medicare and private insurance. Now, we'll cover 3 key differences. First, eligibility. Hospice care is appropriate when curing an illness is no longer possible, generally for people with a life-limiting illness, often defined as 6 months or less to live. Hospice provides help with the emotional and spiritual aspects of dying with a focus on relieving symptoms that are common near the end of life. Hospice also focuses on the needs of family caregivers both during the hospice phase and during bereavement, after their loved one has passed. In comparison, palliative care is specialized care for all people living with serious illnesses, regardless of disease type, stage, or prognosis. People who are actively receiving treatments for their illnesses, such as medicines, chemotherapy, or surgery, can receive palliative care at any point along the serious illness journey. Palliative care does not replace any member of the medical team. Rather, it's an extra specialist added to provide patients and their loved ones with an extra layer of support. Second, location. Hospice care is generally provided at home or in a special hospice center. Hospice caregivers often visit the home a few times per week to help with symptoms and other quality of life needs that change near the end of life. The focus is on providing comfort in familiar surroundings. In comparison, palliative care can be provided anywhere, including in the hospital, clinics, long-term care facilities like rehabilitation centers and nursing homes, and sometimes in a patient's home. Palliative care aims to help people and their loved ones wherever they are receiving their other medical care, in a way that feels coordinated and not separate. Third, working with others. If a person receives hospice care, they generally find it less and less helpful to continue seeing their usual medical team in the hospital or clinic offices. Gradually, the hospice team becomes the primary provider of medical care for the patient as the focus on care shifts to comfort. In palliative care, providers care for patients alongside their usual medical team. Palliative care plays a supporting role to the other clinicians, including the primary care and specialty clinicians like heart specialists, kidney specialists, lung specialists, and cancer specialists. Choosing to include palliative care as part of a medical team does not mean the usual medical team is being replaced. Further, it does not mean that the palliative care clinicians will provide most of the care. They will work together with the patient, their loved ones, and the rest of the medical team members to evaluate how often and how much to be involved.
And then this is just some data that we've shown about the use of this kind of tool. We created one as well for upstream to diagnosis to introduce people to palliative care and what can be helpful for them in terms of bringing this up to their own doctors. And what we created with this, kind of feedback that we got is a tool called ELOS, which stands for Extra Layer of Support. The idea being that from the moment someone has a cancer diagnosis, we want to introduce them through short series of videos and questions to all the supportive care resources that should be available to them. Palliative care, nutrition, chaplaincy, navigation, genetic counseling, clinical trials as well. Because what we recognize that oftentimes people go down this journey and the patient and the caregiver may be thinking about what's the right drug and what's the right interval of that drug that I should be using. But oftentimes as a family caregiver that's sort of thinking about who can I talk to about affording this medication? How do I talk to about clinical trials enrollment? Because I'm not sure I can make that work if I have to bring my loved one to the cancer center every single day, right? And so we introduced those topics in this tool that we created called ELOS. And here's a video that really demonstrates sort of the first kind of welcome to cancer video. What we worked with is patients and family caregivers from the get-go to ask them, if someone gave you a 4-minute video sort of welcoming you to this cancer journey, which, by the way, you don't want to be on it. I don't want you to be on it either. But if we got to welcome you to this, what is key information you want to have from the very beginning? And what you'll see in this video is the basics of how is cancer diagnosed, how is stage come up with, and how do we decide cancer treatments as well.
Knowing what cancer treatments are right and what the future will look like starts with understanding what the word cancer means, how cancers are named, how cancer grows and sometimes spreads, how cancer is categorized, and how doctors treat cancer. First, let's start with what cancer is. The body is made up of many small pieces called cells. When cells come together, they form tissues, which then combine together to form organs. The liver, lungs, and heart are examples of organs. Most cells in the body divide from one piece into two pieces as a way of normal growth or repair. Typically, that growth process is controlled and orderly. Sometimes, the growth becomes out of control and chaotic, and the body's usual control systems can't keep the cells in check. When cells grow in an organ in an unorganized, uncontrolled, and abnormally fast way, we call that cancer. The fuel for this chaos that causes cancer is sometimes known. Sometimes, cancer risk is passed along in families, which is why your cancer team will ask if others in your family had a similar type of cancer. Or, cells can grow out of control because of exposure to toxic things in the environment over a long period of time. But often, the factors that cause cancer to grow are not known. For example, less than 1 in 10 breast cancers has a known cause. Next, let's talk about how cancers get their name. We name cancers by where the out-of-control growth started. For example, a cancer could start in the lungs, in which case we would call it lung cancer. For some people, the cancer moves outside of where it started, a process called metastasis. In such a case, if the cancer started in the lungs and metastasizes or moves to the liver, we still call it lung cancer, not liver cancer. Now, let's learn about how cancers grow and spread. The problem with cancers that spread is, just like how they grow, they spread in a chaotic way that may often involve just a small number of cells at a time. This means catching the spread early on through feeling changes in the body or radiology scans is very difficult. It also means that even when we see the spread of cancer on scans, there's a good chance there are cells we can't see. This makes cancer that has spread more difficult to treat. We categorize cancer using the term stage. Stage is the term used to talk about whether cancer cells have moved from where they started, and if so, how far they have moved. There are 4 stages, numbered from 1 to 4. Generally speaking, the higher the number, the farther away the cells have gone from their original spot, or the larger the cancer is. So, stage 1 means the cancer is just in one specific spot and is not too big. Stage 2 would mean it's bigger, or has spread some, but not too far away. Stage 4 means the cancer has moved far away from where it started. Sometimes, cancer is diagnosed at a lower number, like stage 1 or 2, but despite the best treatments, can still grow or spread, and then become a higher stage number, like stage 3 or 4. In other situations, the cancer isn't found until it's already spread far away from where it started. Cancer doctors typically consider higher stage cancers, like those that are stage 4, as being more difficult to fully treat or cure. Lastly, when cancer treatment options are offered, it's common to wonder why certain treatments may or may not be helpful. Generally speaking, there are 3 ways to treat cancer: cutting it out through surgery, giving radiation to specific parts of the body to zap the cancer cells so they die, and giving treatments that go throughout your system to kill cancer cells. Such treatments that go throughout the body include chemotherapy given through IV or pills, hormonal pills and shots, and newer treatments that come in IV, shot, or pill form. Sometimes we even combine surgery with radiation or shots or pills, while balancing the chance all those things will work with the possible side effects and complications. It's very common, no matter how long a person has been dealing with cancer, to have unanswered questions about the diagnosis, stage, possible treatments, and the future. Or sometimes, it's helpful to ask questions more than once, as these issues are serious and complex. On the next page, you'll see a list of common questions people have who are facing a serious cancer diagnosis. Please pick among the list as many as you want to ask your cancer clinician, and add some of your own by writing them in. Those questions will go into a list on your support map, which you can then use to ask your cancer team.
And then lastly, we created an app called HOPE. It stands for Hospice Preparation Education. This is like ELO's PC for Me, to introduce patients and their family caregivers to the benefits of hospice care and other types of hospice type care, like transitions programs or bridge programs, or care that really provides an extra layer of support in the home that's tailored to where people are in their illness. And what we recognize is oftentimes hospice, for example, is underutilized. Bridge and transitions programs that find people and take care of them even before hospice are oftentimes underutilized. And through this app, the idea is to introduce people to the services so that no one truly feels alone, patients or caregivers going through this journey together with someone else. And the point is there are resources out there, but oftentimes we as healthcare professionals don't do a great job of introducing people and their family caregivers to those resources. That's the type of app that we built here. This is a video of different ways that hospice actually can be structured, even for people who are not actively dying, which is often thought of the time when hospice is used. More upstream is where we want intersection with hospice. And this video will show you sort of examples of ways to receive that type of care.
Many people like you who are facing a serious illness think that the only place to receive supportive health care is in the emergency room, hospital, or clinic. However, it can be exhausting to wait for hours in the emergency room, travel back and forth to appointments, or spend time in the hospital. Being in these places means missing out on important events or time with family. Most people who are very sick eventually prefer to receive care at the place they call home. So, when time is precious, they get more time with the people and things they love the most. Let's look at one person's story. James is a 58-year-old woodworker living with cancer. He wanted to continue working on refinishing chairs, but gets tired easily and has to take long breaks. He was going to the clinic 3 times a week for chemotherapy. After going to the clinic, he did not have the energy to work on his projects the rest of the day. His doctor didn't think he would be cured of his cancer and worried that he would not feel better from continuing chemotherapy. After considering his options and the opinions of his family and loved ones, James decided to receive hospice care in his home instead. Hospice provides a team consisting of a nurse, doctor, social worker, spiritual care counselor, nurse aide, and volunteers who visit his home based on what James needs. At first, James was concerned about extra people coming to his house or coming at inconvenient times. However, His team only comes as often as he needs them and always schedules with him ahead of time. His hospice nurse visits once a week, helping to manage his medication for pain and shortness of breath, and she can call the hospice doctor to adjust medications if needed. His social worker and spiritual counselor check in with him every couple of weeks by phone, helping him to adjust all the changes he's facing. He also knows a nurse aide or volunteer could help him with getting along, like when he needs help getting dressed or with light housework. James feels peace of mind because he can call hospice anytime, day or night, and reach a hospice team member when he needs help. James prefers to receive care in his home and is able to receive the nursing care he needs to help him feel good and be independent enough to put together a beautiful oak rocking chair he promised his granddaughter.
And with that, I'll stop there and just want to say thank you for listening. My email address is there, as is my Twitter handle. I talk a lot about the delivery of high-quality hospice and palliative care and really the support of family caregivers. What I want to demonstrate to you over time is there's actually a lot of legislation in Congress right now that's emphasizing the identification and, in fact, even payment of family caregivers are doing that work. So it's an exciting time now to be an advocate for family caregiving and to join us together in terms of the importance of the family caregiving work that's happening across the country and the world. Thank you very much.